All right, let's jump right into it. Today, we are breaking down some of the most critical obstetrics maneuvers out there. Whether you're reviewing for clinical practice or gearing up for high-stakes exams, these are the fascinating, life-saving techniques we use to safely guide a baby into the world. Let's get started.
So here is our game plan for this explainer. We're going to walk through a logical clinical pathway. We'll start with Leopold maneuvers, check out fetal heart sounds, run through normal delivery baselines, and then tackle the heavy hitters, shoulder dystocia and breech delivery.
Section 1. Leopold maneuvers, assessing the fetal position.
Okay, so when we're trying to figure out exactly how the baby is situated in the womb, we use these 4 grips. Now think about your physical stance here. For the first 3, the fundal, lateral, and pollex grips, you're facing the mother. But for that 4th one, the deep pelvic grip, you actually have to turn and face toward her feet. Let's zoom in on that high-yield 4th maneuver for a second, because there's a huge misconception here. Just because the baby's head has entered the pelvis, that doesn't automatically mean it's fully engaged. The secret is literally in your hands. If your hands converge or come together, the head is not engaged. But if they're forced outward and diverge, right there, that's your true sign of full engagement.
Moving right along to Section 2. Fetal heart sound, locating the heartbeat.
Finding that tiny heartbeat absolutely shouldn't be a guessing game. It completely depends on the baby's position. The ultimate visual landmark here is the mother's navel. So if the baby is head down, a cephalic presentation, you're going to listen below the umbilicus. If it's a breech presentation, you shift your stethoscope above the umbilicus. It's that simple.
Section 3. Normal delivery, standard clinical baselines.
Now, let's talk about safely guiding the baby out. You all know the Rubin maneuver. If the head pops out too fast, we're looking at severe perineal tearing, which we obviously want to avoid. So what do? We slow things down. You use your dominant hand to control the occiput, the back of the head, controlling that exit speed. Meanwhile, your non-dominant hand uses a sterile towel to give firm support to the perineum. And hey, remember, there's a modified version of this too, which basically keeps your hands totally clear of the amal area to minimize any contamination risk. During a routine delivery, you might suddenly run into a neutral cord, where the umbilical cord is wrapped around the baby's neck. Your next move is entirely dictated by tension. If it's loose, no big deal. You just gently slip it over the baby's head. But if that cord is tight, you've got an immediate hypoxia risk on your hands. Don't try to force it. The protocol is to clamp and cut the cord right then and there, absolutely before you even try to deliver the shoulders.
But what happens when a totally routine delivery just stops? The head delivers perfectly fine, but then forward progress completely halts. What is your very next move if that shoulder gets completely wedged against the maternal pelvis? That brings us to Section 4, shoulder dystocia, managing impacted shoulders. This right here is a massive obstetric emergency, and you need swift action. These interventions stack by severity, so you've got to memorize the exact clinical order. We always start with primary, external adjustments, think McRoberts Maneuver and Suprapubic Pressure. If those don't work, we escalate to secondary, internal maneuvers for rotation and extraction, like Rubin, Wood's corkscrew, or Jacquemet. And if things get entirely critical, we hit tertiary, which are your drastic final measures. Remember, you never, ever skip a tier.
To keep this all straight under intense pressure, Helper PR is your ultimate memory anchor. Call for help. Evaluate for an episiotomy. Legs back from McRoberts. Apply suprapubic pressure. Enter for those internal maneuvers. Remove the posterior arm. And finally, roll the patient onto all fours, also known as the Gaskin maneuver.
Let's actually visualize one of those vital secondary maneuvers, Wood's corkscrew. Imagine a really tight bolt that's just completely stuck. You can't just yank it out, right? You have to unscrew it. It's the exact same concept here. You insert your fingers internally and rotate the baby's posterior shoulder exactly 180 degrees. This effectively unscrews the baby, dramatically changing the diameter and dislodging that impacted anterior shoulder.
Now, if literally every single thing we just tried fails, we land on the Zavanelli maneuver. This is your absolute final resort. You are quite literally pushing the fetal head back into the birth canal so you can rush into an emergency C-section. It sounds extreme because it is, but knowing this high-yield tertiary intervention is what saves lives when all else fails.
All right, final stretch, Section 5, breech delivery, navigating complex presentations.
Let's say you're dealing with a frank breech. The baby is coming down buttocks first and their legs are extended straight up by their ears. You absolutely cannot just pull the leg. Instead, you use Pinard's maneuver. This is a classic exam topic. You insert your fingers, naturally flex the baby's knee, and gently bring the foot down into a graspable position so you can safely deliver that leg.
Okay, so the lower body is out, but now you've got to deliver the arms. Enter Lofset's maneuver. This one is all about rotation. By taking the baby's body and rotating it 180 degrees, you're using the natural pelvic angles to your advantage. This lets you smoothly slide the baby's arms out from right under the maternal symphysis pubis, the front pubic bone. You just rotate one way to get the first arm and back the other way for the second.
Finally, we reach the most dangerous part of a breech birth, delivering the after-coming head. We have a specific stack of procedures for this. First is the MSV maneuver, where you flex the baby's maxilla, the upper jaw, while applying pressure to the occiput. Then we have the gravity-assisted magic of the Burns-Marshall technique. You literally let the baby's body hang so gravity provides natural traction. But remember, this is only done after the placenta separates. And last up is Brock's maneuver, where you're gently lifting the baby completely up and over the maternal abdomen so the head can deliver spontaneously.
We have covered some incredible, high-stakes ground in this explainer, and I want to leave you with this final thought. Obstetric emergencies don't hit pause to let you go check a textbook. When seconds literally mean the difference between life and death, are you fully prepared to step in and execute the exact right maneuver? Thanks so much for joining me today, and I'll catch you in the next explainer.